Great. So thanks for coming out tonight, everyone. I'm going to be speaking on evidence-based diagnosis of gluteal tendinopathy. So the main learning objectives for today are to understand the greater trochanteric pain syndrome in terms of its relevant anatomy, and then look at the clinical presentation, try to look at the main disease culprits, and identify evidence-based clinical exam maneuvers and diagnostic tests. So in terms of the relevant anatomy review, we're looking mainly at glute med and min and their origin points. So basically, glute med is originating on the dorsal ilium, as well as the posterior superior iliac crest and coccyx sacral junction down here. And then you're also looking at glute minimus, which is originating on the dorsal ilium between the anterior and inferior gluteal lines, and they both insert onto the lateral greater trochanter over here. So looking at the bursa, there's actually three, consistently described bursa, I should say, that are relevant to our talk. So they all link to one of the gluteal muscles. So you have the subgluteus maximus bursa, medius, and minimus bursa. And basically, the bursa are working to try to cushion the myotendinous junctions. So in terms of GTPS, it's described as lateral hip pain with peritrochanteric pain and localized tenderness to palpation. The incidence in North America is described between 10 to 25%, and the risk factors are all associated with altered lower limb biomechanics. So women are at higher risk because of the way that their pelvis is shaped. It's about a 4-to-1 ratio described in the literature. Also, if you have IT band pain or knee-OA, that also puts you at greater risk in the literature as well. And the average age of presentation is greater than 50 years. So if we're looking at clinical presentation of GTPS, just to review, you're looking at, again, lateral pain near the greater trochanter. If it's radiating anywhere, it's going to radiate directly down the lateral thigh. So if it's crossing more medially, you're thinking more radicular patterns of pain. And then anything that really aggravates the greater trochanter or insertion of glute med or min is going to sort of aggravate the lateral hip pain itself. And so you really want patients to point directly to where the pain is in order to help with the clinical history taking. So one of the biggest questions for GTPS is what the most common pathology is. It was thought for many years that it would be GT bursitis, and that's actually not the case. So literature from the late 90s and early 2000s has shown that glute med and min tendinopathy is actually fairly common as well. And so there was a study done about 4 years ago looking at ultrasonography of GTPS, and they were trying to prove how rare primary bursitis actually was. So their goal was to use ultrasound to determine the sources of GTPS. So they looked at ultrasound exams retrospectively from January 2005 until December of 2010, and they used these search criteria while they were looking through the ultrasound examinations. So you notice that they're all anatomically relevant, not really relevant to the patient's clinical history, so we'll come back to that as one of the downsides of the study later on. They included patients who had GTPS on their history or ultrasound-guided palpation with those terms found within the ultrasound exam reports, and they excluded patients who'd had repeat ultrasound exams or hip arthroscopies. So if we look at one of the examples here, you can see there's the glute max muscle, and there's the greater trochanter, and there's this area that's a bit anechoic in this region. So that's just the fluid, and this was consistent with GT bursa or diagnosis GT bursitis, specifically in this patient. So some people might ask, well, how do you tell whether or not that's just the normal bursa versus actual bursitis? And in terms of radiographically, usually they look for a distension of the bursa itself, so there's actual measurements that they will use in terms of the bursa to determine whether or not it's actually supposed to be pathologic or whether that would be considered within normal limits. In this patient, they actually were able to aspirate 20 milliliters of fluid. So that's one example where ultrasound is sometimes a better tool to use over MRI because you can actually treat the patient at the same time. This is another example. This one is of glute med tendinosis. So the first picture is a coronal view, and the image on the right-hand side is the transverse view, and it's basically showing thickening of the glute med tendon. So you can see those striations, or what they call a normal fibular pattern, is sort of lost in the area where the arrow is, so it's becoming more indistinct, and that would be consistent with glute med tendinosis. So looking at the results of the study itself, they basically found 877 unique patients with GTPS. There was 602 women and 275 men, so a little bit off from the 4-to-1 ratio described in the literature. The average age was 54, which is consistent. 700 patients did not have bursitis on ultrasound, but actually 177 of them actually had some element of greater trochanteric bursitis. So you can see that the numbers for bursitis alone is not that significant, but in terms of bursitis being an entity within their findings, it's actually around 20%. In terms of gluteal tendinosis, that was around 49.9% in terms of it being a component of the clinical findings overall. So the study was trying to conclude that GT bursitis was quote-unquote only present in 8.1%, but what I found when I was looking at it was GT bursitis as a clinical entity was actually present in 20% of patients. Also, interestingly, 13% of patients didn't have any abnormalities, and again, this could be a flaw of how the study was conducted itself because they were looking at anatomical search terminology instead of patients' clinical symptoms, and then they could either have clinical symptoms on history or have ultrasound-guided tenderness to palpation on the examination itself. So again, it's kind of vague in terms of how they defined their study population. Other weaknesses would be that they were an academic center, so obviously not as generalizable. And it was a single radiology reading with varying experience of the two radiologists. So the two radiologists, one had 2 years of experience and one had 15 years of experience. So there were major discrepancies in terms of, as you know, ultrasound, MSK imaging is like a very specialized field. And so that was kind of a huge factor, I thought, even though it wasn't really something that the study heavily emphasized. Did you guys have any questions or comments about this one?
What do you think explains the discrepancy between isolated 8% bursitis and the 20%?
So I think the problem with GT bursitis, looking at other studies that were conducted with MRI, is that they found that GT bursitis is a very difficult finding to correlate with patient symptoms. So they've actually done studies, larger studies, with looking at pelvic MRIs overall, and they found that a large percentage of patients were found to have bursitis in terms of the pathology that they would measure radiographically, but they didn't actually have clinical findings. So I don't know if that's maybe the reason why the isolated bursitis was so significant, because that might be a variant of normal, or just differences in how radiologists actually measure their findings. I'm not 100% sure. But the GT bursitis compared to the actual gluteal tendinopathy, which we'll get into in the next study, is a little bit more inconsistently described.
I mean, I guess what I was wondering also about was, is the discrepancy also that those with concomitant GT bursitis and tendinopathy or partial tear, is that bursitis secondary to the tendinosis or the tear?
Right. So why the incidence of it on its isolated incidence is so low?
Yeah.
Could be.
So then you'd add that number to your tendinopathy number as well.
Basically.
To make it really high.
Yeah. So moving on to the second question that we want to, and then this is just sort of the conclusion. So considering the possibility of tendinopathy plus or minus bursitis, as opposed to thinking GT bursitis is the main reason why people have GTPS. So the next major clinical question that we had were, what are the best clinical tests for diagnosing gluteal tendinopathy? So can anyone name some causes of lateral hip pain?
Back pain radiating to the hip.
Yeah.
Osteoarthritis.
Good. Yeah.
Trauma.
Good.
So what kind of trauma? So what are the different things you can get?
I don't know, last time we talked about like a stress fracture there.
Yeah.
Possible. If you get trauma to like direct like blunt trauma, you could actually have a fracture. Yes, it could be like muscular injury as well.
Great. So you can see in this diagram here there are several different patterns of pain, but really there are several mimics that can kind of mimic lateral hip pain, even though classically they may not present with lateral hip pain. So any intra-articular hip pathology, so OA, FAI, femoral stress fractures, supposed to present with anterior groin pain, but again, patients might perceive it more as being lateral. Again, L2, L3 radiculopathy in the anterior thigh, or L5 radiculopathy posteriorly, as well as anything referred from the back, so lumbar facet syndrome or discogenic pain can also refer to that region as well.
Can you name one thing that's not on that list? Can you think of anything else that might cause localized pain, especially over the greater trochanter? I think trauma might be associated with swelling, fluctuant swelling. Have you heard of a Morel lavale? So essentially you can get a separation of the fascial layers. Typically it happens with somebody who's either had a fall and there's essentially a sliding pattern where their skin gets caught and their body keeps moving, and then they'll get a large fluid collection. They can get like a seroma and stuff like that. So it's another thing to keep in mind. If you see quite a bit of swelling and there's been a traumatic history, there's no fracture, that's one thing you might be considering that could be localized in that area.
Okay. Thanks, Neil. So the second study that I wanted to look at was actually published earlier this year. It was looking at the utility of clinical tests to diagnose gluteal tendinopathy that was confirmed via MRI in patients presenting with lateral hip pain. So this was a population study, and again, their reference standard was MRI, and their inclusion criteria was that they needed to be between 35 and 70 years old with lateral hip pain that was at least a 4 out of 10 for most days within the last 3 months, so much more specific than the previous study in terms of what they were looking at. In terms of the clinical tests, so they looked at palpation. So palpation has been widely described in the literature. It's a specific test for GTPS. So that's the main reason why that was the key clinical diagnostic criteria. And so patients would be lying with their affected side facing upwards and their hips flexed at 60 degrees with their knees together. And then if they had tenderness palpation on insertion of the glute med or min tendons, then that was considered positive. They had several other criteria that they looked at. So Faber, that the patient had the lateral mallet of their affected leg placed above their kneecap on the other side, and then their knee was passively lowered into abduction and external rotation. They had Fader, so the Fader position is in figure 1 up there, and basically the examiner would be passively adducting and externally rotating their hip. They had Fader R, which was Fader with resistance. So again, that same position, but resisted isometric internal rotation against a force applied by the examiner. They had adduction, so in figure 2 at the bottom, the patient was lying diagonally with their symptomatic side facing up, and then they tried to keep the patient in neutral rotation, and then the examiner would put them into passive adduction. and then adduction again with resistance. So then the patient was asked to apply abduction against resistance applied by the examiner. And then they also looked at single leg stance. So the patient was standing with their affected side facing away from a wall. They were allowed to touch the wall with their fingertips for balance, and then the knee facing the wall would be bent at 90 degrees. And then they were asked to stand on their affected leg for 30 seconds, and if it was painful at any point in time, that was considered positive. So clinic.
Yeah, go ahead.
Sorry, the AD deduction versus resistance is actually, she's applying AD deduction, but the patient's abducting, correct?
Correct.
Okay.
And then for that single leg stance, I think it's, so are they're not facing the wall.
They're not facing the
They're
wall,
side
so
to
they
the
were
wall, right?
parallel to the wall,
Yeah, okay.
and their affected side would be facing outwards. And
Their affected side is further from the wall, but
correct.
Gotcha.
Right,
Why
so
is
the
that?
side that,
What's that?
Why
because
does that
it's just
matter?
the side that they're balancing on, I guess, would be, like, it's not the side that has the wall for support, I suppose.
Oh, they're allowed to use support?
They're allowed to touch with their
Yeah,
fingertips for
fingertip
support. That's how the study design was.
Sure, okay.
I'm not sure if that's how we necessarily always do it
Yeah.
in
Good.
clinic, probably never, but that's just how that's just how the exam was, probably for medical legal purposes, so they didn't.
It's also a weird way of describing, we would describe that as AB deduction versus resistance, that test, as opposed to ADD versus resistance, right?
So
Because
it's
the
like,
patient's abducting against
Yeah.
resistance, even though the force we're using is an adductive force,
yeah.
right? So if I was testing rotator cuff, I would say external rotation versus resistance. I wouldn't say internal rotation versus resistance.
The way I understood it was, it's like this, right? Where you're standing, you're testing the away from the wall side, right?
Right.
And so you're like, so
I
this,
think
this
Neil's
is actually
talking. I think
against the
Neil's
wall.
talking about the other test, though.
Oh,
He's
sorry,
talking about the
are we talking about
fader.
different tests?
Yeah, I'm talking about the
Okay,
ADR.
sorry.
Yeah. But a single leg stance would be similar to Trendelenburg, right?
Yeah.
Which has been described in previous studies that you should be using it for minimum of 20 seconds anyways to look for neural fatigue, but sorry.
Yeah.
I see
So
what you're saying.
so I understand what you're saying because it's so when they say it's resisted, it's the force that the patient's applying. So they're applying an abduction force. And so the actual terminology is very confusing because the ADD-R test is actually an abduction test.
Thank you.
And the fader-R test is a Faber test, but with resistance.
Okay, yes, okay.
It's just
Yes,
it's just a
yes,
confusing
yes.
study, but that is how it's described.
Kind of looks like it was photoed at an auto show on a showcase stage.
They're pretty good lighting though.
Yeah, look at
Pretty
the lighting on
lighting.
the outside. You can
Yeah.
see it looks like there might be a Tesla out there or something.
Yeah. Good use of space, I guess. So in terms of the results, it's a bit of a confusing table, but we'll go through it step by step. So there were 65 participants. 20 participants had gluteal tendinopathy on MRI, but they were clinically negative. And 34 participants had a positive clinical diagnosis, so they had positive palpation plus one other test. Whereas 50% of the MRI reports actually identified gluteal tendinopathy. So if you look at the first row there, so the clinical diagnosis of gluteal tendinopathy, it's a bit confusing because GT stands for gluteal tendinopathy, not greater trochanter. So 30 of the patients who had gluteal tendinopathy were detected using palpation plus one other test. But 20 patients were found to have gluteal tendinopathy on MRI, but not detected on the clinical testing. So if you look at the sensitivity, that calculates to 60%. So you could do that for each one of those numbers in terms of true positives and true negatives and false positives and false negatives. So that's how they ended up with all those different numbers at the top. And then basically what they found was a very high positive predictive value and moderate sensitivity and specificity. So if you look at palpation, which was their primary clinical diagnostic criterion, it had the highest sensitivity out of all of the clinical tests. So if palpation was negative on clinical testing, it helped to rule out gluteal tendinopathy, and that's reflected because it had the lowest negative likelihood ratio. So looking at all of the other tests beyond palpation, they had very high specificity. So single leg stance in this population had specificity of 100%. So every single patient that tested positive with single leg stance had gluteal tendinopathy on MRI. However, there were 31 patients who were negative on that test who also had gluteal tendinopathy on MRI. If you look at the fader and adduction tests versus the resisted versions of those tests, the positive predicted value and sensitivity and specificity and negative predicted value all increased. And that would make sense because you're adding sort of this active tension component to the passive tension and compressive component of that test. So when they just used the test itself without any active tension, they were relying on the passive tension and the compressive component based on the patient's positioning on the exam. And then if you have the active tension component, sort of just proving the point that your diagnostic accuracy is increased. So did anyone have any questions or concerns with this?
I mean, the question you want to ask is what is our gold standard for gluteal tendonitis? I don't know. Do we have one?
So that's a great question. So it actually comes up in the discussion points for this study. So if we look at the most sensitive clinical test, that's obviously palpation. The most specific clinical tests were the single leg stance and the two resisted tests. And the study basically concluded that a combination of these tests is best because none of the positive likelihood ratios contained one. It's consistent with other studies. So there were smaller studies conducted, one in 2008 that looked at 16 patients with trochanteric tenor bursitis, and it found that SLS and resisted external derotation, so resisted Faber, had high sensitivity and specificity. But the study weaknesses, so a small sample size of 65 patients, but it's actually one of the largest, I think it's actually the largest study of this type conducted so far, because the other study was only about 16 patients, and another one I found was 21 patients. And using the MRI as a reference standard, you're 100% right, Neil, it's not necessarily a gold standard. So a lot of people have found that ultrasound might be better in terms of visualizing calcific tendinosis, but the problem, I guess, comes in terms of diagnosis. Like, you need to be pretty certain that that's the main thing that you're looking for if you're going to use the ultrasound, because then you're able to treat them right away. If you're trying to rule out any of those other mimics, or if they're a complicated patient and they're not presenting just with lateral hip pain, they have other confounding symptoms, then you're probably going to be ordering an MRI in most places anyway. And also, I guess this also comes back to ultrasound imaging and MSK specialization within ultrasound, and whether or not that's going to be convenient for a lot of people out in the community. Maybe not.
Okay. What do you use for testing for gluteal tendonitis?
Usually, so I guess one thing is, at least clinically, to distinguish between tendinopathy and GT bursitis, but then, as I was saying, often they are concomitant. If they have tenderness on palpation when you're palpating directly, I usually get them to lie on the presumed affected side, and then sort of side lying load that, so that's on the bottom side. If they also have tenderness to palpation on the bottom side, and to me it seems like there might be a bursitis component to it, and then I'll usually image at that point. If they only have tenderness to palpation, and then I flip them onto the affected side, press down, and there's no sort of reproduction of their symptoms, I don't image them. I just treat it as gluteal tendinopathy.
Okay. So I actually bring, I don't know if this is right or not, I bring them into, one of the things I found very helpful for the gluteal tendinitis is I bring them into an Ober's
Yeah.
and then test them against
from there.
resistance.
Kind of like that add-R.
But it's extension of the hip, right? That's flexion, adduction, external rotation,
No,
resistance.
how about the second one? That one sounds like.
Do you
at
mind
least the
going-
image.
going
Yeah.
back,
You Go
please?
back
Yeah,
to the
sure.
image.
So that second one,
Yeah.
yeah, except what I'll have them do in that position is with a flexed knee, I'll then have them externally rotate, or sorry,
Oh. Internally
externally
rot-
rotate. No, is it? No, it's just I guess it's similar to that. I have them push up with I use a greater lever point, I guess, which I don't know, maybe it's not as accurate. I'll go down to the foot. That's
Like I'll do
probably-
that after I sort of distinguish which one it is. Because I figure if there's tenderness on the lower side when you're pushing down on it, then there may be some, like if there's GT bursitis as well, then at that point we can decide on whether to intervene with that or not.
So the other interesting point, I guess, is do you find that when you send patients for imaging, that the MRI results are in keeping with their clinical picture, or do you think that there sometimes is nothing?
I actually can't. I don't recall a single patient I've referred for MRI imaging
Yeah.
of gluteal
It's just
tendinitis.
So that's good then, because that sort of supports, I think, the evidence sort of supports your decision not to send them. There was one other study that I didn't get to mention about MRIs, and they looked at 256 pelvic MRIs, and they didn't have any knowledge of the patient's clinical symptoms when they did the study itself. And clinical symptoms were only present in 16 of those patients, but they found peritrochanteric abnormalities in 212 of the unaffected patients.
So
So
there's a lot of incidental.
there's a lot of incidental findings on MRI, and it's like a really expensive thing to order if you're just kind of trying to rule a bunch of things out.
I'll do X-ray before I do MRI. Like if you're thinking about lateral causes, so FAI or hip OA, but sometimes you'll also pick up the calcification proximal to the greater trochanter
On X-ray.
on X-ray.
Which is interesting because they haven't done a lot of studies with that with gluteal tendinopathy. They've only really done
That's the issue. So that would be what population? What specialty do you think that population would most likely present to?
orthopedics or
Will emerge actually. So
really?
calcific tendinopathy. So that's where they'll present with like anywhere from like a 7 to 10 out of 10 pain, and often atraumatic. And you'll end up getting an X-ray, and you'll see this like less radiopaque than bone, density on either the shoulder X-ray or the hip X-ray, but very, very, very painful.
Very responsive to cortisone. Have you done that merge?
I haven't followed them up. Very treatable with cortisone. I don't know how effective the treatment is though, because I don't see them in follow-up.
So basically, the take-home points for GTPS are that gluteal tendinosis is more common than GT bursitis in patients presenting with lateral hip pain. A combination of clinical testing involving active muscle contraction increases your diagnostic accuracy. And then finally, the presence of abnormalities on both ultrasound and MRI have poor correlation to patient symptoms. So sometimes things are seen and the patients don't have symptoms, or they have symptoms and nothing is seen on MRI or ultrasound.
Excellent. Thank you very, very much. Fantastic topic.